We have a very industrial conceptualization of healthcare right now. Whether we articulate it or not, the infrastructures of healthcare are based on an industrial model. They're based on the idea that anybody will do in any role. And so a person who's responsible for counting the number of employees and the number of hours might think, well, the way we're going to be most effective is to shift people around and have this medical assistant and this nurse fill in here and fill in there, and not prioritize stable relationships.
When you speak to policy leaders in primary care, most will say something along the lines of, the future of primary care is teams. But as you just heard from Christine Sinsky, an internist, an expert in primary care practice design, decisions about team structure tend to be driven by financial considerations. And financial considerations often mean substituting someone who's cheaper to employ, like an advanced practice practitioner, for a physician. But financial considerations aside, the reality is we don't actually know a lot about how to optimize a primary care team. In fact, we don't know a whole lot about teamwork in medicine at all. In 2019, I wrote a 3-part series for the journal about teams. Part of what drew me to the topic was just my general fascination with the sociology of medicine. So for instance, I'd started noticing how the more people you have involved in any one patient's care, the less likely it was for any one person to assume overall responsibility. And so I wrote a bit about what sociologists call the bystander effect, which describes how people are less likely to help a victim in need as the number of bystanders increases. Essentially, responsibility gets diffused, and we assume someone else will take care of it, which I think happens all the time in medicine and contributes to patients feeling like their care is fragmented. But what really fascinated me was that we spend so much time in teams, and we actually know very little about what makes them function well. One major exception is the work of the Harvard Business School professor Amy Edmondson, who described the concept of psychological safety in the 1990s while studying hospital teams. I wrote a whole essay about the concept, so I can't do it justice in a few sentences, but the essence of psychological safety is the idea that on any given team, there's a shared understanding among team members that they can take interpersonal risks. Things like asking questions, admitting errors, or making suggestions. The concept of psychological safety has now taken on a life of its own, to the point where I've actually noticed it sometimes gets weaponized as a way to dismiss tough feedback or expectations around hard work. But psychological safety isn't meant to sanitize our work environments or compromise rigor. In fact, the opposite is true. It creates an environment, particularly in teams that are traditionally hierarchical, where teams can constantly improve because they're clear-eyed about their deficiencies. So fast forward 6+ years since I wrote that essay, and though this primary care, team-based future is upon us, I think we know even less about how to optimize a primary care team. What we do know, however, is that advanced practice practitioners comprise an increasing proportion of the primary care workforce, cost less than physicians to employ, and increasingly substitute for physicians entirely. So given these changing workforce demographics, what would an ideal primary care team look like? Can we assume APPs are as safe and effective as primary care physicians? And when it comes to teamwork, where do we need more science? And when can we rely on common sense? I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. My first guest, Hannah Naprash, you heard from earlier in the season. She's a health economist at the University of Minnesota who's done some work studying teams. And she started out by emphasizing these shifting workforce demographics.
The big shift I'm talking about is the rapid growth of nurse practitioners and physician assistants who are providing primary care. They're also providing plenty of specialty care, but today's a primary care day. And The thing we don't know there is how much they function as substitutes for primary care physicians versus complements, right? How much do they provide primary care services in the same way a doctor does versus do they work as a team?
This challenge contributes to our inability to define the meaning of a team.
Anytime somebody brings up teams, my immediate question is, what is a team to you? And the answer is always incredibly different. And I think that reflects tremendous variation. There doesn't seem to be consolidation into the optimal primary care team. There isn't really a consensus emerging. With that said, the team members have changed a lot. And the number of practices that employ one or more nurse practitioners as a team member does nothing but increase. It's even harder to study the quality of teams than it is to study the quality of individual clinicians, because the first thing you have to do is define who is a team. Do they think they're a team? Does the patient know they're a team? Are they always a team? Is it only for some patients, right? Like, let's say you can totally nail it down and you're like, okay, physician A always works with this set of advanced practice clinicians and other supporting personnel. Then you're still in that world of how do we define quality? What are the quality measures that we trust? How do we compare quality between a team that looks like this and a team that looks like that? And it just makes it that much harder. There is some work I've seen that uses especially electronic health record data to look at what happens to patients when they're seen by interdisciplinary teams versus single practitioners. And they look at chronic condition measures over time, and it looks like teams that have membership from multiple types of clinicians, physician and nurse practitioner, physician and physician assistant, do somewhat better. Again, all the caveats I said earlier about how hard, right? Like they may assign patients differently. There are all sorts of things that might make those apples and oranges. But I think they've gotten as close as anyone has to really doing this comparison. So there's a little bit of evidence. But with that said, I don't think there is any paper I've seen that actually tells me, okay, if I were going to start a primary care practice tomorrow, how would I structure? Who would I hire in order to guarantee that I could provide the best possible care? I have no idea what that answer is. And I think probably the hiring decisions are driven more by the economics of it, right? There are huge salary differences between physicians and nurse practitioners. It's about twice as much, though it really depends again by specialty. It depends on the economics of it and also on who you can get, right? So this is part of why we're seeing this change in the mix of primary care clinicians.
In determining which professionals should make up a primary care team, the existing evidence, as Hannah just described, doesn't help us that much. But because APPs make up an increasing proportion of the primary care workforce, a lot of research is focused on whether APPs and physicians deliver the same quality of care. Hannah described the 3 types of evidence we have to answer this question. She mentioned an RCT, which I'm going to return to, and then the following 2 types of data.
So the next category of evidence would be quasi-experimental. That's my jam for sure, because I'm a health economist. And there are researchers who have used, again, the emergency room context of effectively quasi-random assignment of patients who show up on a day when there are lots of nurse practitioners working versus lots of physicians working. And they find really different results. So they find that resource use is much higher. The number of tests and imaging studies that are ordered by NPs is higher than it is for physicians. And they also find that the rate of 30-day readmissions is higher if you see a nurse practitioner in the ER versus a physician. Okay, so RCTs, quasi-experimental. Then you have this huge third category. This is where almost all of the studies are. And that category is basically compare outcomes and control for the kitchen sink, right? And everybody does this knowing that the patients who see physicians versus nurse practitioners are different in ways that we can and cannot observe, right? This is a really mixed literature. I would say that this literature overall shows that quality of care is fairly comparable. There are some caveats there. There's also a pretty strong finding that patient satisfaction with nurse practitioners might be higher than it is with physicians. My strong hunch there is that nurse practitioners spend more time with their patients on average. And a big driver of patient satisfaction is just, did you have enough time with your clinician? So those are the three categories of evidence. They tell a really mixed picture. I don't feel like I have a concrete answer to that question based on the evidence that we have. And we really need it because we see that, especially rural areas, but also low income areas, the mix of the primary care workforce is shifting away from physicians and towards nurse practitioners and PAs in a pretty rapid fashion.
Given the unreliability of the observational data, and the fact that the analysis using pseudo-randomization was in an emergency department setting, I want to spend a moment talking about one randomized controlled trial. So this RCT, called Primary Care Outcomes in Patients Treated by Nurse Practitioners or Physicians, was published by Mundinger et al. In JAMA in 2000. The outcomes of the trial included patient satisfaction and health status, as well as physiological measures of asthma, hypertension, and diabetes. And the study found that these outcomes were basically equivalent at 6 months, with a few minor exceptions in both directions. And this finding that outcomes were comparable, whether patients were treated by physicians or NPs, is why this trial is so often invoked to justify NP-independent practice in over half of U.S. states. But when you look at these results, I think a critical question arises. Do these outcomes adequately reflect what primary care actually is, especially as it's practiced nearly 30 years later? So a few caveats that contribute to my own skepticism. First, patients who'd already received diagnoses of these diseases were preferentially recruited from emergency departments or urgent care clinics. That's why in interpreting the results, it's important to remember that a lot of primary care requires diagnosing undifferentiated disease. And second, if the foundation of primary care consists of longitudinal relationships, do these physiological measures really tell us anything about quality? Or do these outcomes instead tell us how well people can follow an algorithm for treating 3 common diseases? I'm sure my bias is coming out here. And in that sense, maybe the most important finding in the emergency department study that Hannah described, which was led by the physician and health economist David Chan, is that there's significant heterogeneity within each profession. Meaning we all know wonderful APPs and bad doctors, and vice versa. Mary Rose, our producer, has a primary care clinician who's an APP who completely turned her life around when she diagnosed Mary Rose's anemia and presumed gastric ulcer. And until we discussed the topic this season, Mary Rose just assumed her clinician was an MD. And I think that probably happens a lot. But given the uncertainty of the data, as well as the stories we all throw around to support our priors, it's tempting to argue that we just need better science to answer this question about whether APPs can simply replace physicians in primary care. But I think there are some questions where excessive focus on science can lead us astray. Science relies on measurement, and a lot of what I think makes primary care good just can't be measured. Does this mean APPs can't provide excellent primary care? Absolutely not. I've heard from so many primary care physicians about the outstanding APPs in their practices, one of whom you're going to hear from in a little bit. And also, we desperately need APPs in primary care. Recent data published in JAMA Internal Medicine show that between 2013 and 2021, the number of PCPs available for new patient visits among Medicare beneficiaries declined. And even though the number of APPs in primary care grew during the same period, it wasn't enough to offset the decrease in physician availability, which anyone who's tried to get a PCP recently probably already knows. But experience matters for all clinicians. As Polly Smooey, a young family medicine physician who you heard from on episode 9, told me, I learn from NPs all the time. An NP with 20 years of experience is a better primary care clinician than I am. But that recognition that experience matters is exactly why it doesn't make sense to me to assume that a group of people who undergo far less training end up equally well prepared to take on some of the hardest work in medicine. And maybe some of us shrug at this prospect of physician substitution because we don't conceptualize primary care as some of the hardest work of medicine in the first place. Christine Sinsky, who you heard from at the beginning, practiced primary care for 32 years in Dubuque, Iowa, before having leadership roles at both the ABIM and AMA. And as you'll hear, I think Christine conceptualizes the primary care team differently because she conceptualizes primary care differently. Here's Christine describing how she and her husband, also an internist, developed a primary care team for their practice.
Our team was really strong, and I was very fortunate about that. And I don't believe it was uniquely because of the special skills that these particular people had. I think it was the roles were brought in. And so the team was 2.5 nurses per physician. One nurse was the primary nurse, and she was like the quarterback of the practice. And she was the one who would do all of the coordination when patients needed to be referred, patients called in. She would be the most likely one to take their calls. She would be the one who would schedule people in who needed to be worked in that day for an urgent problem. She would be the one who would identify if they needed to be sent to the lab or for an x-ray before they saw us. Many of those things she would do by protocol or by our having discussed that ahead of time for other patients. And then the other nurses were the rooming nurses. We called them the help nurses. And they would then room the patients. And toward the end of our practice, we developed what I think was our strongest model, which we called our comprehensive care model. And in that model, the nurse brought the patient back, did the vitals, reviewed with them the preliminary results of their labs that they had done before the appointment. They might do some patient education. If the patient was there with back pain, they might start to ask about the nature of that back pain, what had brought it on. They might even bring out some of the exercises that we would do for back pain. They would certainly pull up any relevant x-rays or labs or previous notes that related to a new concern that the patient had. Then they would come out and we'd have a mini huddle, and the nurse would tell me what was going on for the patient.
Then they would go back in together. Christine, having been briefed, could focus on the patient, and the nurse still had a clear role in the patient's care.
Toward the end, the nurse would stay in the room with me, with the patient, and she would start to queue up any orders. As new problems came up, she'd pull up relevant information. So it allowed her to be part of the conversation with the patient. She might say, oh, and remember, you want to tell the doctor this. And it allowed me to just give my full and undivided attention to the patient. And then when the patient and I and the nurse together had come up with a plan, and sometimes the nurse would say, hey, do you want to get this? Don't you think we'd like to do that? And they were usually right about that. So it was nice to have trained people that had been trained over time in our practice who could be part of the diagnostic and therapeutic team.
A nurse would then stay behind to make sure patients understood any new therapies, as well as the follow-up plan.
That allowed me to then leave that room. All the work for that patient was done. All the orders were in, the documentation was done, and then I could move on to the next patient with a free and clear mind, and I could totally then switch gears and focus on them, and likewise down the line.
I don't think you can understand what makes for an ideal primary care team without first understanding what makes for ideal primary care. And one key aspect to Christine's comprehensive approach was that she and her colleagues cared for their patients when they were admitted to the hospital as well. Because the members of Christine's team all worked so closely together, everyone knew all the patients well. That meant that Christine could afford to spend time in the hospital without worrying that outpatient needs were being left unaddressed. And for those who were acutely ill, having their own doctor care for them could change the course of their lives. Here's Christine describing how knowing someone well, and over time, helped her care for one of her more complex patients.
He was a middle-aged male who had widespread vascular disease, and he had had multiple amputations for peripheral vascular disease, starting with his toes, then the midfoot, then BKA, and then an AKA. And he also had mesenteric ischemia, so he'd lost sections of his bowel, and he'd also developed heart failure. So he'd had multiple hospitalizations over a 5 to 6 year period of time. And I had seen him in all of those hospitalizations. But he would often be admitted while I was not on call. So one of my colleagues would admit them, and then I would see him and carry on. And so I really had an intuitive sense of him, as well as like a deep knowledge of the course of care that he'd had. And it wasn't at all uncommon that the handing off physician would have written him off. And one time in particular, I know that all the physicians involved felt like this was the end of the line for him. He was obtunded, he had widespread anasarca, his renal function was off. And when I came back, I said, maybe, but we've been here before. And I think that we should not assume that there's no possibility of recovery to a reasonable function. And he did recover, and he had several more years of life, most of that time living independently.
Given the comprehensive nature of her practice, including caring for patients in the inpatient and outpatient settings, I asked Christine what she thought about APPs substituting for primary care physicians.
I think one of the challenges in suggesting that APPs can simply replace primary care physicians is that I think people are confusing how much something is paid and valued with how difficult it is to master and how much training is required to master it. I think if we evolve to just a touch and pass model of primary care where patient triaged immediately elsewhere, that's what will come from lesser trained individuals delivering the majority of care. And I just think that would be unfortunate for patients and for society, for those who pay for care, for those who care about quality and safety.
I have been humbled so many times this season reporting on primary care, confronted again and again with perspectives that force me to recognize when I'm wrong or off base. And one such moment happened as we were in the final stretch of putting together this episode. I got an email from Katie Waller, an NP, an assistant professor in health and community studies at Western Washington University. And what Katie suggested was that my framing was wrong. Why keep asking whether APPs can replace physicians? She wondered. Why not instead acknowledge that APPs are a critical part of the solution? Urging me to take a more generous look at these skilled professionals, Katie reminded me that NPs have already been functioning as primary care clinicians for decades with full panels of their own. Now I'm going to quote her. "I'm not trying to replace anyone or take anyone's job," she wrote. Emphasizing the shortage of primary care clinicians, Katie said, "We are not a threat, but a partner in the solution." And I think she's right. But I also think if the two professions are to partner effectively in delivering primary care, it's fair to take a hard look at the adequacy of APP training. And the thing is, Katie seems to think so too. She's a huge advocate for structural changes that would make it easier for NP students to get their requisite preceptorships, because under the status quo, there's little financial incentive for experienced clinicians to train NPs in clinical environments. As a result, they're often left on their own, traveling all over the country, accumulating significant debt, simply to secure the clinical training they need to be effective. And even though, as you're about to hear from our next guest, Antonio Sanchez Gonzalez, transitional programs are emerging to give APPs more advanced training, these programs are not universally required, and those that do exist are not always accredited. Antonio's a nurse practitioner and a primary care clinician at Oak Street in Providence, Rhode Island. Oak Street's a primary care network owned by CVS that serves Medicare patients with an emphasis on value based care. And Antonio, despite being relatively young in his career, has already had a handful of leadership roles, including some involving clinician education. So I asked Antonio about the APP training landscape. And as you'll hear, he described the need to create more accredited transition programs, which offer recent graduates a period of more focused training.
I can speak about nurse practitioners and PAs specifically. I know, having gone through clinical training during COVID, having this fragmented training and not having preceptors available sometime and trying to struggle to get your hours in, it really makes it difficult sometimes to feel that you're confident and prepared to take care of patients right away. So the biggest thing that I think is an opportunity for all of us is to really build those transitions to practice programs, just like they exist for physicians after formal graduate training.
Oak Street has built one such transition program.
There are over probably 500 of these programs now, but only about 45 of them are accredited. And again, it's a very rigorous process where the program has to show not only that they provide good onboarding for these new professionals, that they have continued mentorship, that they have a certain set of competencies, and not only that, but the program has to be already running for a few years before they can demonstrate that they've met this high quality accreditation.
But not everybody has to do it, right?
Not everybody has to do it, exactly. So historically, like I said, most of the nurse practitioner transition to practice has been on-the-job training, like it happened for me. I didn't have a formal postgraduate training. And at that point, it really depends on whether the physicians that are available in the organization have the time and the dedication, and they are invested in the success of that practitioner. So that's why, again, there's variety, and it really takes people that really believe in advanced practice providers and ultimately the high quality care for primary care to be the mentors of those up and coming primary care workforce in nurse practitioners and PAs.
One thing I learned while trying to understand the training landscape was that it can often be difficult for NPs to find preceptor sites because there's often no incentive for physicians to serve as preceptors. So I asked Antonio how these transitional programs approach this challenge.
So I cannot speak for all of the programs, but I can say that some of the ones that I've looked at, they do have incentives for the primary preceptors of those nurse practitioners. And there's usually just not one preceptor, but there's multiple preceptors, and this is really important. For instance, in the Oak Street Health Primary Care Fellowship, we have a primary preceptor that's usually the person that meets regularly and does case reviews with the nurse practitioner fellow. But we also have secondary preceptors that actually see patients with the fellow on a daily basis. And additional to that, when the preceptor is seeing patients on their own, they have a virtual preceptor that's available all the time, and they are actually encouraged and required to discuss every case with them. So this also frees up the primary care providers that are in the clinic seeing their own patients. So it really takes a team to provide that structured and well mentored program to make this fellow successful.
And how long is the transitional program?
So in this case, specifically the Oak Street Health one is a 12-month paid program.
So, what is the political landscape like? Like, why isn't this universally required? Or do you think we're moving in that direction?
So I do think we are moving in that direction simply because most nurse practitioners themselves believe that this is the way to go. This is how you become more competent. This is how you learn to be a really safe and efficient provider. And not only that, but it really ultimately just teaches you how to properly work within a team that is able to, again, know the scope of practice that you have, when to escalate, when to consult specialties, and work in this collaborative model. One of the analyses that they've done recently is that between 2013, where about 14% of the visits were delivered by NPs. Now in 2019, there's 25% of visits across multiple specialties, not just primary care, are actually delivered by nurse practitioners. And for Medicare patients specifically that had at least one or more visit, by 2019, 41% of them had a visit with an NP or a PA. So we're really embedded into the workforce across the entire healthcare system. But most importantly, in primary care, we're delivering that care for lower income individuals, in rural settings. And based on the studies that have been done, randomized controlled trials and systematic reviews, we're really providing comparable outcomes in patient satisfaction and quality of care as opposed to physician-led primary care.
Do you ever notice pushback from patients who feel like they want to see an MD as opposed to an NP or vice versa?
Yeah, absolutely. And that sometimes happens, and it really stems from a lack of education and knowledge about their profession, lack of knowledge about our training and what we can do.
What do you think if you and I were to be talking 10 years from now? I hear all the time that NPs and PAs are going to just replace physicians as primary care clinicians. Do you think that that's in our future imminently? You're shaking your head. Tell me why no.
I don't think so. Look, I wouldn't have been able to get to where I am today if I didn't have great physician mentors that had extensive training who provided me with the opportunity to learn and really become excellent at what I do. So again, we always will need people that know more than us. And when I'm saying that, it doesn't mean that it's necessarily a physician mentoring a nurse practitioner. It could be a more seasoned nurse practitioner mentoring another nurse practitioner. I mean, I can give you an example. Just yesterday, I was seeing a very complex patient that we were trying to prevent an avoidable emergency room visit. And she actually had come out of the ER. So I was reviewing her chart. We were trying to figure out what was going on. She had presented initially with a possible asthma exacerbation due to RSV. But upon taking a more closer look at her chart, I realized that during the emergency room visit, they had done an EKG, and this had shown atrial fibrillation. The patient left the emergency room visit without knowing that this had happened, and nobody communicated with her about it. I was the first one that I was like, "Wait a minute, do you have AFib?" Upon doing the physical exam, indeed she had an irregular pulse and rhythm. We did an EKG, and sure enough, it showed AFib. Upon reading this EKG, because the patient had a larger body habitus, the EKG quality perhaps wasn't the best. So I just wanted to have another set of eyes. So I escalated to my senior medical director, Dr. Betaj, who quickly discussed the EKG with me, and we both agreed, yes, this patient indeed has AFib, and we were able to get her on a beta blocker, anticoagulated, discuss the risk with her, and really, set her up in a better course. So again, it's all about collaborative care. It's about escalating when you need to and really having that wraparound model to provide better patient care.
It's helpful to hear concrete examples describing both APP's role in providing primary care as well as how they might be integrated into the primary care team. But if teams are to be the future of primary care, it's worth acknowledging the heterogeneity. Christine traveled around the country observing various primary care practices. So I asked her what she observed about teams.
I observed a couple of things. One is that when people use the term team, they can mean very different, almost diametrically opposed things. For some, teamwork is this very fragmented model where you see one person for your hypertension, someone else for your heart failure, someone else for Coumadin Clinic, someone else for diabetes, and there's no coordination. They're all on the same team, but it's just very fragmented care. That's not what I believe strong teamwork can be. I also saw generally the lack of any teams, that it was a solo model, the doctor on their own, that there might have been someone who escorted the patient to the room and did a blood pressure, but then never spoke with the doctor, never explored any of the patient's social or medical history with them. And even if they pick up something, there was no mechanism for which they would connect that to the physician. So mostly what I saw was the absence of teams in various places. And I actually saw something that surprised me. It was just this very much of a disempowered stance that physicians were in, that they really felt the lack of any agency or control over really even the most basic aspects of their practice. And so that was surprising to me.
I do think there are some exceptions where you see physicians not only having agency, but using it to create novel approaches to teams. Ray Witt is a primary care physician and hospitalist at the University of Nebraska Medical Center, who practices in an innovative model her division has developed that allows physicians to straddle both worlds. Basically, two physicians are paired who then split their time between the inpatient and outpatient settings. The model arose in response to physician desire for broad spectrum practice, including inpatient care, which was becoming tougher in the academic setting. Here's Ray explaining how her hospital leadership innovated for the new system.
Our boss at the time was creative. He was a staunch advocate for general internists and was just trying to figure out how to keep recruiting to primary care. And he had heard about this hybrid model at a different institution 10 years before and said, let's try this. Let's see if it works. And so launched the model with 2 physicians. The hybrid models were 2 physicians split, 1 full-time outpatient FTE, 1 full-time hospitalist FTE, but they rotate back and forth between the 2 domains every month. And so the physicians would get a practice in both settings, but separated in space and time. They'd have protected time to do it, which was different than the traditional model.
Some logistical issues were quickly sorted out. Everyone, for instance, decided that it made most sense to manage their own in-baskets. But the hybrid model also forced some ingenuity when it came to the structure of the primary care team.
Some of our clinics are staffed with APPs who predominantly are there to see patients who have acute needs. The APPs don't have their own panel of patients. And so in my clinic, that's the case. And if my patient needs to be seen in a month that I'm on a hospital service, we have a ton of APP support that can see those patients on short notice. Other clinics didn't have that same level of support. So then the physician pair would have to talk through, okay, well, I'm going to leave an acute slot or 2 on my template every day so that I have room for either my patients or your patients that need this more acute, timely care in order to ensure all the patients' care needs were met in a timely manner. We've seen a ton of enthusiasm to the point where it's funny because we're in interview season for our residency, and so many of our applicants are like, what is this hybrid system that everyone keeps talking about? Is that unique to you guys? And I say yes, and part of me is like, but it could go anywhere. This is why I want to share this. A lot of us that do this job like our job so much. I think we're just constantly talking about it and smiling at work, and we're happy with our careers. And so it creates this positive momentum where our residents get excited, then they pursue it, then the residents a year or 2 below them see people going into primary care or choosing the specific job, and they get excited about it. And the really cool thing is in the last 5 years, we've also had more residents choosing full-time careers in primary care, again, because I think they see this positive feedback loop happening. And so it's been great for the momentum around careers in primary care for us.
Another novel approach is being piloted at the VA, where APPs have been authorized to practice independently since 2016. In this new model, primary care doctors serve as part-time general medical consultants for patients whose assigned primary care clinician is an APP. So instead of, for example, referring to cardiology or endocrinology as the current system requires, this model allows APPs to consult assigned primary care physicians for more complex cases. For those physicians practicing primary care, it means freeing up some of their outpatient slots to see these more complicated patients. Part of the goal is to improve and consolidate patient care. So for complex patients tossed between different specialists, struggling with mixed messages and unanswered questions, having a competent internist take charge can be life-changing. But professional identity is at stake too. If the model works, it would allow primary care physicians to spend more time caring for patients needing their advanced medical skills or expertise. To be clear, both types of clinicians are integral to providing care. But the hope is to allow primary care physicians to have an identity organized around medical complexity rather than panel size. And yet, for the profession at large, I can't help but wonder, why do we invest so much on quality improvement, which disproportionately affects primary care, and then, at least under some circumstances, just assume that the mastery required for practicing good primary care can be obtained with much less training? Here's Christine on the mindset that may be driving some of this evolution.
Like, we have a very industrial conceptualization of healthcare right now. Whether we articulate it or not, the infrastructures of healthcare are based on an industrial model. They're based on the idea that anybody will do in any role. And so a person who's responsible for counting the number of employees and the number of hours might think, well, the way we're going to be most effective is to shift people around and have this medical assistant and this nurse fill in here and fill in there and not prioritize stable relationships. But I think that's a mistake because I think we get the outcomes we look for, whether they're revenue outcomes or the quality outcomes or the access outcomes, if we have stable teams, for example, if we move away from the industrial model and realize that relationships are the secret sauce of healthcare, that in the end, we are in a relational business. And when we move away from decades of neglect of the relational aspects of healthcare and prioritize the design of healthcare around relationships with our patients, with our physician colleagues, with our team members, care is going to be so much better for the patient, for the physician and team, and for those who are responsible for the financial aspects of care.
In an interview Christine did in 2010, which was published in the Journal of General Internal Medicine, she talked about what she observed when she visited primary care clinics across the country and how she noticed how so many were working in chaotic, unsupported environments. These challenges, in turn, were leading to fewer people wanting to do primary care. When Christine was then asked what physicians should seek from hospital leadership, this is what she said. We don't ask our surgeons to go into the operating room and gather all the instruments out of the cabinets. We don't ask them to scrub the operating site. We don't ask them to fill out the demographic part of the pathology requisition slip. We recognize that this would be a misuse of a limited resource. However, in primary care, and in many cognitive specialties, the physician is doing the equivalent of gathering the instruments and filling out the pathology slips. And I think that's really unfortunate. It does not make sense to have people who've been so highly trained filling out demographic information or typing their notes or going through a 10-click process to order a test or medication. Those are things we've worked to have our staff do. End quote. This theme of devaluing primary care physicians is one I've been harping on all season, but I bring it up in the context of teamwork because I was struck by the analogy Christine made to surgeons. The hierarchical nature of surgical teams is so obvious to all of us that the analogy makes total sense. And when you think back to this concept of psychological safety and its importance to teamwork, it's critical to know that Amy Edmondson, who developed the concept, devoted a considerable amount of her work to surgical teams. And my guess is that's because surgical teams are so inherently hierarchical that psychological safety becomes more important so that those lower in the hierarchy feel comfortable speaking up. Psychological safety is also important to primary care teams. In fact, as you heard Christine mention, her nurses would often ask questions or point things out in ways that were critical for patient care. But I do think it's telling that in primary care, the hierarchy is less implicit, because if we, as a profession, were more viscerally attuned to this hierarchy, there'd be greater investment in helping primary care physicians spend their time in ways that make use of their unique expertise. So what does this mean for teams? I think for primary care teams to deliver high-quality care, we need teams to be stable. We need APP training to be better funded and to include more accredited transitional programs like the one Antonio described. And though I think we need the humility to recognize the critical role APPs are playing in delivering primary care, I also think it's okay to acknowledge why hierarchies exist in the first place. Primary care physicians undergo rigorous training to master a distinct skill set. And for that mastery to be put to best use, a little hierarchy might go a long way. I'm Lisa Rosenbaum, and this is Not Otherwise Specified from the New England Journal of Medicine. The next episode of NOS will be our final for this season of primary care. Stay tuned.
I think it always comes back to the patient, because I know the patients really need us. And so when I walk into an exam room, I think it's probably just because I'm older, of course, and have experience, but I don't feel as compelled to make sure that I'm checking off all the boxes, because I know the patient wants me for something else. And I always have the phone, and I always have ways to say, I'll see you again soon, or we can talk about this later. And now we have the computer to email people, but the relationship and actually the visit is never over. It's just part of a continuum. And I think that that's really important.
That's next up on Not Otherwise Specified from the New England Journal of Medicine. I'm Lisa Rosenbaum. Our editor is Debbie Molina. Our producer is Mary Rose Madden. Adam Strauss is our audio engineer. And I also want to thank all of my colleagues at the Smith Center for Outcomes Research at Beth Israel Deaconess Medical Center. They've helped me to conceptualize this season and to identify the most pressing and unexplored challenges facing primary care. My article series on primary care can be found at nejm.org, and our email is nos@nejm.org. I'd love to hear from you.